my part is to talk a bit about the pharmacovigilance. In oncology, more than any field in medicine, we have new toys, as Kim says. So every year at every conference, multiple times a year, there's new drugs, and with new drugs comes new side effects. And some of them are very difficult to decorticate. We sometimes have to, I personally organize a conference just dedicated to toxicities to bring on experts and discuss on, how can we better recognize them? How can we better improve safety for our patients? And it is a learning curve because most of our drugs are approved based on efficacy first and foremost. I mean, obviously we look at toxicity because otherwise they wouldn't make it past the trials. But the implementation is often lightning fast in oncology, and it's only with time that some of the toxicities and the patterns emerge, and it's not always obvious for us to decorticate and realize what's serious and what's not, and that's where maybe AI could come and help us. So as Dr. Gilbert said, important with the conflicts of interest, here are mine. So let's start with a case. I mean, you have a patient who's, let's say, on immunotherapy for breast cancer or some other kind of lung cancer, and then they call a symptom hotline, or so it says, I have new cough, new shortness of breath, and I've taken my saturation at home, oxygen saturation, it's about 95%, so not terrible, and what should I do? So with a patient who's, let's say, on immunotherapy, a shortness of breath could be potentially the first symptom of something extremely serious, which is an immune-related pneumonitis, which is an inflammation triggered in the lung from the drug we're giving them. And everything here matters in terms of how fast we recognize it and how fast we start treatment for the patient. And I'll put you two scenarios side by side, the traditional way of how we're doing it and how the AI pharmacovigilance can help us ameliorate this process. So I've put you in a few steps how this works. I'm going to put it now in an animated form so you can see. So first, patient calls. Who does the call go to? Well, it depends on the time of the day. If it's a daytime, it could be a nurse. If it's a nighttime, it could be a doctor. But most of the time, the symptom management hotline is actually managed by nurses who are in oncology and who triage the first call. And it might take a few minutes to take the full history and do the whole triage. So next, so once the nurse has taken the call, again, assesses the symptoms, writes everything down, but the next step is a lot of the time the nurse will not be able to make the final decision on whether this is serious or not. This is not just simple side effect of chemotherapy like nausea, constipation, where there are clear protocols. When somebody is on a new drug or a drug which has potentially a life-changing toxicity like pneumonitis, then oftentimes the call has to be escalated to a physician. It might start with the resident. The resident might then have to call their staff. And a lot of the time, the staff will call another staff who's the expert in that kind of toxicity. So there's a chain of events that each of time might be delayed for reasons or another. One staff might not be available, how long it's going to take for somebody to answer their page. So there's a lot of variables that go into this to ultimately to come up with a final decision. So the last person in the chain of command, who's the expert, quote unquote, will then assess the symptoms in their head, assess, okay, what is the likelihood that this is something severe, and then triage the patient accordingly, whether to be an outpatient treatment or send them to the emergency room. And after all that's done, whenever we have time, because we don't always have time, you have to go in the chart, document, very important, so that, let's say, if the patient shows up in the emergency room, maybe not now, but maybe later, so the ER doctor knows that this symptom has already been triaged and that there has been some recommendation already made. Because a lot of the time, if you don't do that, the patient will show up to the emergency room and the ER doctor will have to start from scratch and go through all the whole calling process of calling the resident, who then call the staff, who then call the expert again. So it becomes a very redundant and non-efficient system. And the time to resolution might take minutes or it might take hours, sometimes it might take a day, which is, again, time is money here. Some of these toxicities, the faster you start the treatment, the more mortality you're going to reduce for the patient. So let's now compare this to a different model where an AI pharmacovigilance tool can help us go through the whole process again. So let's now do the same process, but using, let's say, a call center, a pharmacovigilance call center. So your patient calls. Now it's not only daytime or nighttime. It's 24/7. It's available. Anybody can reach the hotline at any time. It will then take the history and then summarize everything. So now, which is the important part, is that instead of going through a chain of like different command and calling different people, the AI model, based on the data that's been provided, can then triage and do a risk estimate on what is the probability of this being a serious side effect, which will then require urgent assessment. And this will depend heavily on how you have programmed the model and what kind of inputs you've put it, what kind of thresholds for sensitivity, specificity, what kind of prevalence for the toxicity. So I'll get to that a bit later too quickly. So then the action that will result out of this will depend, again, on the thresholds that you would have set. If, let's say, it's a low probability of serious adverse event, it could potentially be managed as an outpatient or maybe a same-day visit to oncology clinic. But if the risk goes high based on the model that you've generated, then it will probably require an ER visit, and those would be the serious cases. And then, hopefully, again, to save us time, and like everybody else said, the AI could potentially, even if it directly linked to the EMR, generate the note of the intervention directly in the patient's chart, again, saving us doctors valuable time to actually see patient and provide care. And this whole process can hopefully be shortened from hours to potentially a day to maybe an hour or less, depending, again, on the model we're going to use. So, again, I think the advantages are kind of obvious in terms of what it could do. So it's a 24/7 service. The risk stratification is not based on subjective assessment, but by objective data that drives a risk model and can tell you what's the likelihood of the patient being sick and requiring an ER visit. And then the documentation, and what's also very important is that the models can self-learn and adjust based on what happens over time. And let's say maybe your center, because a specific patient population has a more prevalence of a certain toxicity than what's reported in the literature, then the model can adapt to your reality and then again, provide a more personalized care. So I'm gonna, I think, skip over this for sake of time. So it's not also all positive. So we have to have certain things in mind. And I will maybe summarize all of them in one important thing, which is in programming, that there is a saying which says garbage in, garbage out, meaning the effectiveness of your model depends really on what kind of input you've given it, what kind of data you've given it to be able to calculate risks. So if your inputs are bad or not consistent with reality, then the model can become very risky and actually do provide like false assessments or false risk assessments, which could be potentially dangerous. And for that reason, a lot of the models have safety nets, meaning, let's say if a certain symptom is reported, let's say patient says, I have taken my saturation and it's below 90% at home. So regardless of all other data or input, it can then short stop the rest and say, okay, this requires an emergency visit. But again, most importantly is that a lot of the time we don't have these data to fit to the models, the pharmacovigilance, because these data emerge over time with more follow-up in real-world evidence. So we have to have that in mind, is that we shouldn't, hopefully this will complement the old way we're doing it, but not necessarily fully replace it. And I think that's it.
I was wondering, I have a patient who I wanted to start EV Pembro, but their A1C is 9. What should I do about that?
It's pharmacovigilance and then.
Okay. Hi, Glenn. Thanks for your question. With an A1C of 9, that's quite elevated, as you know. Before starting EV Pembro, it would be important to optimize the patient's glycemic control, since both enfortumab vedotin and pembrolizumab can increase the risk of hyperglycemia and other metabolic complications. Ideally, you'd want to coordinate with the patient's primary care or endocrinology to get the diabetes better managed before starting therapy. Unless the cancer situation is urgent, in which case you'd need a careful risk-benefit discussion and close monitoring. Would you like Jamil to follow up with any specific recommendations or a call? Or do you want to leave a message for him to review?
Leave the message.
Leave the message.
No, I'm okay, thank you.
Donc, merci Cash, vraiment très
You're
impressionnant.
welcome.